Good afternoon. We will get started in a couple of minutes.
Hello, and welcome to Columbia Health. We're here to help you stay healthy so you can focus on your studies and all that Columbia and New York City have to offer. Columbia Health offers a broad range of on-campus services, including routine and urgent medical visits, short-term mental health counseling, sexual violence prevention and advocacy services, disability services, along with educational and skill-based health and wellness programs. These services are available to students as part of the Columbia Health Fee. For more information about Columbia Health or to make an appointment, please visit us online. Take advantage of these campus resources. After all, your health is up to you. Be well, Columbia Health. Hello.
Good afternoon, and welcome to a Columbia Student's Guide to Monkeypox, what it is and how to manage. My name is Alicia Czachowski. I am the Senior Executive Director for Alice Health Promotion. Welcome. We realized that there have been many questions and concerns about monkeypox among members of the Columbia community. So we wanted to bring together a group of experts from across campus to really talk through what Columbia's response is going to be and is currently, and answer some of the frequently asked questions that we have been receiving. At this point, I'm going to turn it over to the presenters to introduce themselves. Wafaa, if you'd like to start.
Yes, absolutely, and apologies for delay. I'm Wafaa El-Sadr. I'm a professor of epidemiology and medicine at Columbia University. I'm also the executive vice president for Columbia Global, and it's my great pleasure to join you today.
Hello, I'm Daniel Chiarilli, he, him pronouns, and I'm the Associate Director of the Gay Health Outreach Project, part of the Health Promotion Office at Columbia Health, and also a sometime adjunct assistant professor in the music department.
Hi, my name is Katherine McAvoy. I'm the Assistant Director for Public Health Initiatives. I work really closely with our contact tracing program here at the university, and I'm located within Alice Health Promotion.
Hi, I'm Rick O'Keefe. I'm a family physician and one of the senior primary care docs at Medical Services. And I have, during this past summer, cared for a number of the students who have been diagnosed with monkeypox.
Hi, good afternoon. I'm Eduvigis, Cruz-Arrieta. I'm one of the psychologists at the CPS Counseling Center, and also a member of the behavioral health team that collaborates within medical services. And I'm very glad to be here today.
Hi, good afternoon. My name is Colleen Lewis. I'm the Senior Executive Director of Disability Services here at Columbia.
Before we get started, just a couple of notes. There is a question and answer feature. If you have any questions throughout the webinar, please feel free to post your question in there and we will answer at the conclusion of the webinar. And closed captioning is available. All you have to do is go to the bottom of your screen and click the closed captioning button and you'll be able to see a live transcript. For our first section, we are going to talk a little bit about the current state of monkeypox and to provide a little bit of background information. So I am going to turn it over to Professor El-Sadr.
Thank you very much. And I'm going to share my screen. Oh, sorry about this. Oh, sometimes there are snafus. It will take a minute, but let me just. I'm sorry, can you see my screen or no?
We see monkeypox testing and diagnosis.
Okay, hold on for a second. I'm not sure why this is happening since we tested it before. Just. How about now? Do you see it now? Are you able to see the screen?
Not seeing your screen right now.
Not seeing it.
No.
Would it be helpful for us to share the slides?
I think that may be necessary.
Thank you.
Apologies.
One moment, please.
Thank you. Apologies. Okay, great. Okay, thank you very much. And again, apologies for the delay. So I'm going to provide the monkeypox update to all of you today, and I'm eagerly await your questions during the question period. Next slide, please. So here's an update, and just here's an outline of my presentation. I'm going to start by touching a little bit on the monkeypox virus itself and its history, and then talk about the epidemiology of this current 2022 outbreak, describe some of the key clinical features of this outbreak, touch on vaccination and treatment, and end with a brief summary and conclusions. Next slide. Next slide, please. So let's talk about the monkeypox virus itself. This is what we call a viral zoonosis, which means that it's a virus that's transmitted from animals to humans, and which causes very similar symptoms to those that we have seen in the past with smallpox. However, it's important to remind everyone that fortunately, the symptoms that are caused by monkeypox virus are much less severe than those that have been reported historically with smallpox. And this virus belongs to what we call the orthopox genus of the Poxviridae family of viruses. And it was discovered in 1958 when there were two outbreaks of a pox-like disease that occurred in monkeys that were kept for research purposes. However, the first human case was first identified of monkeypox was first identified in 1970. Now, prior to the 2022 outbreak, essentially cases of monkeypox were reported often from several West African and Central African countries. And that's why we call these the countries where historically monkeypox has been reported previously, or these are the countries where this virus has been endemic. Now, there are two different kinds of the virus. One is clade 1, which is more severe, and one is clade 2, which is the one that's responsible for this current outbreak. And fortunately, that's the one that causes less severe illness. Next slide, please. Now, what are the modes of transmission? And I'll touch on the modes and then get into the symptoms of monkeypox. So very importantly, at the top, you'll see the main route of transmission is through direct prolonged skin-to-skin contact with an individual who has a rash or sores that are caused by this virus. And this transmission, skin-to-skin contact and transmission, can occur during sex or during other intimate activities. There are less possibly other routes of transmission, although again, the most important route is what I talked to you about already, and that's through contact with what we call fomites, which are clothing, bedding, towels, or other items that are used by somebody who's diagnosed with monkeypox. And then possibly through respiratory secretions when somebody sneezes or coughs, that can be, again, passed on between an individual with monkeypox and somebody else through prolonged face-to-face contact. It's really important to remind everyone that this virus is very, very different from COVID-19, from SARS-CoV-2 virus, the virus that causes COVID-19. With SARS-CoV-2, the coronavirus, we know that it can be transmitted very easily and usually and can be transmitted from someone without any symptoms, and also can be transmitted from what we call casual contact. This is not the case with monkeypox, where, as you see here on the slide, the major route of transmission is direct, prolonged skin-to-skin contact. The symptoms, after somebody gets infected with the virus, the symptoms usually appear within about 3 weeks or so of the exposure to an infected person, and the illness itself lasts between 2 to 4 weeks. In most people, and I'm very carefully saying most people, the symptoms are usually what we call self-limiting. And what I mean by self-limited is that they will really go away by themselves without the need for any treatment. But about a quarter of the people who've had monkeypox during the current outbreak may have more severe symptoms and may require to take some treatment. Next slide, please. Now, how do we diagnose monkeypox itself? This is diagnosed by a healthcare provider who will take a specimen from an individual who comes in with suggestive symptoms of monkeypox. And then the provider will send the specimen to the laboratory for testing using a very highly accurate PCR test. And to collect the specimen, the provider, what they'll do, they'll take a swab, as you can see on the upper right-hand corner, a swab, and they will run the swab and rub vigorously across the lesions, the rash, or the sores on the body to collect enough material on the swab to be able to detect the virus if it is present. It's also possible as well to send the scab from a skin lesion, send that to the lab for detection of monkeypox. Now, a PCR test, as I mentioned, is conducted to detect orthopox viruses. This is the whole family of these viruses. And usually the result is obtained back or available within a few hours after it arrives, within a few days after it's sent to the laboratory. However, it's important to keep in mind that while you're waiting for the results of the test itself, it's really important to take all the precautions to prevent the spread from monkeypox to others while awaiting the results of the lab testing. Next slide, please. Now, what's going on now in terms of this monkeypox outbreak globally? You can see here on this figure that as of October 5, there have been a total of about 70,000, more than 70,000 cases that have been reported globally. And then you'll note that more than 69,000 of those cases have occurred in countries that have not historically reported monkeypox in the past. And during this outbreak, only about 700 or so cases have been reported in countries that have historically reported monkeypox. And those are the countries in blue on the map that are in West Africa and in Central Africa. I need to caution, though, that this number that's been reported here in terms of what we know about the occurrence of cases in the African context may be an underestimate, and that's because testing is not widely available in those countries. So in all likelihood, that's a way underestimation of the current burden of monkeypox cases in those countries. Next slide, please. Now, as you can see here from in the United States overall, there have been to date more than 26,000 cases of monkeypox that have been detected and reported, and 2 deaths have been reported. And you can see again from the map of the United States, and the different colors of blue really reflect the burden within those countries. The darker the blue, the higher numbers of cases reported, that it has been reported from almost all of the US states. But the good news, as you can see that on the right-hand side of the slide in the figure, is that it appears that this outbreak in the United States has peaked, and we're now seeing a decrease in the daily numbers of cases that are being reported in the United States. So that's the good news. Why is this happening? It could be for a lot of different factors. Number one, it could be that people are more aware about monkeypox. So if they develop symptoms that are suggestive, they're going to their provider, and the provider is sending a specimen to the laboratory. So earlier detection of infection, earlier isolation of cases, of course, prevents transmission from one person with monkeypox to another. That could be factor number one. Number two is that there's also been access to vaccination in this country, which may also have had an impact in decreasing transmission. And thirdly, we have evidence to suggest that there has been changes, or there have been changes in certain behaviors, which may have led also to a decrease in the risk of transmission, particularly amongst the most affected population. Next slide, please. It's important to go take a look at who is being reported with monkeypox in the United States. And this figure shows from May of 2022 to the end of September 2022. And you'll note that early on in May of 2022, that about half of the cases were reported amongst white individuals, and about the other half were reported amongst Blacks and or African American. Over time, you'll notice the change, and you'll see that now the majority of cases in September are in this magenta color. The majority of cases are being reported amongst Black or African American individuals, while a smaller proportion among Hispanic, Latinx individuals, and a smaller proportion amongst whites. So there's been an evolution over time, with now the most severely impacted subsets of our population have been African American or Black, as well as and Black men in particular in this country. Next slide, please. Now, what's been happening in New York City? And to date, there have been more than 3,600 cases of monkeypox that have been reported in our city. But you'll see again reassuring data from the figure on the right. We also peaked in August or so, and now there's been a rapid decline in terms of the daily numbers of reported cases, as you can see on the right-hand side of this epidemic curve, which is good news, indicating that we are seeing a decrease in the numbers of cases in New York City, as well as overall in the country. Next slide, please. Now, what are the critical demographic and clinical features of a person with monkeypox? And these are results from a case series across 16 countries that included more than 500 cases. You can see on the right-hand side here some of the lesions, some of the sores, some of the rash that can occur on the skin, people with monkeypox. But also you can see as well, there could be sores around the mouth, in the throat, as well as in the perianal area, as you can see in these pictures. So what's distinguishing this outbreak is that there's not only are there skin sores and skin rash, but there also are these this rash and these ulcers that have been noted in the mouth, as well as also in the perianal area in the rectum. But what we know from this series of cases is that 98% of persons were gay or bisexual men. In the series, 75% were white. About 40% were individuals who were living with HIV. And the transmission has largely occurred amongst individuals through sexual activity. You'll also note that 95% of individuals presented with a rash. And some of the common symptoms are listed here. Other symptoms preceding the rash have included fever, enlargement of the lymph glands, weakness, muscle aches, as well as headache. And then, as I mentioned before, from infection to manifestation of symptoms, the range is from 3 to 20 days. 13% of persons in this series needed to be hospitalized, but no deaths were reported in this series. And most of the hospitalizations were because of severe symptoms, especially when the sores were in the mouth, limiting the ability to eat and drink, or they were in the perianal area or in the rectum. Or also cases amongst people who have underlying conditions, medical conditions, and had more severe illness. Next slide, please. Now, this is a series looking at the characteristics in a series from Europe, and you'll see here again, similarly, that again, the majority have been amongst males. You can see that most of the transmission has occurred during sex. About 38 to 40% have occurred amongst people living with HIV, and that thankfully the majority of cases have been mild cases, non-serious cases. Next slide, please. Let's move on to vaccination and treatment. Thank you. Next slide. The good news is that we have preferred vaccine that seems to work quite well for prevention of monkeypox. This is what's called the Genius vaccine, and this vaccine contains a non-replicating virus, which means that the virus itself can't replicate in the body. So getting the vaccine, you can't get monkeypox from getting vaccinated. And that's very important to keep highlighting this. It is the preferred vaccine. It's recommended to be given in 2 doses, 4 weeks apart. It's administered now in the skin or right under the top layers of the skin. And you can see here the eligibility in New York City includes people who've had multiple anonymous sex with partners in the last 14 days and identified either gay or bisexual, or other men who have sex with men, also transgender, gender conforming, gender non-binary individuals, as well as also individuals who've had transactional sex or sex at certain venues, as well as also importantly are individuals who've been informed by the health department that they have been a close contact of someone with monkeypox. Next slide, please. And we have data that tell us that this vaccine works, which is very important. You can see here on the left-hand side of this figure is that there were, in this one series, there were 14 cases amongst people who did not receive vaccine, and only 1 case amongst the person who has received 1 dose of the vaccine. And this was amongst people who were eligible for vaccination and who should have been vaccinated as quickly as possible. This is good news that we have evidence, early evidence that the vaccine works. Next slide, please. However, what we've noted is this disparity in the distribution and inequity in the distribution of the vaccine. And these are data from New York City. And I want you to focus in the middle of the slide. And you'll see here in the darker blue, in the lighter, if you look at the white population, for example, you'll see that in the lighter purple is about 45% were eligible for vaccine, and about 48% of the vaccine doses were administered to this population. Well, if you look amongst Blacks, you'll see the disparity is quite evident. There you see that about 13% were eligible for, 31% were eligible for vaccine, and only about 13% or so of the doses were administered to Blacks who fit into the population eligible for the vaccine. So we have a disconnect. We have more people who are being reported with monkeypox among Blacks and African Americans, but fewer of the population are getting vaccinated. New York City is doing a very good job in terms of trying to reach the diversity of individuals who should get vaccinated with the establishment of vaccination sites in the highest affected communities, having mobile units that are working and going to venues where such individuals may be accessing those venues, with an effort, a concerted effort to try to reach the population at highest risk. Next slide, please. What about treatment for monkeypox? Also, the good news is that we have treatment, an antiviral treatment for monkeypox, and it should be considered in individuals who have severe symptoms, severe infections, those who have high risk for progression to severe disease, including people who are immunocompromised, people who are living with HIV, as well as individuals who may be pregnant or breastfeeding. In general, in the bottom bullet here, you'll see that the treatment is not recommended for the majority of people who often have mild illness. So this is recommended only for a subset of people diagnosed with monkeypox. Next slide, please. Now, what this outbreak has highlighted is the importance of paying attention to stigma and discrimination. And as you know, of course, that stigma means a negative association between a person or a group of people who share a certain characteristic. And this is often fueled by fear or anxiety, can result in discrimination. And we've known from many, many different experiences, and this is the most important aspect of this, is that it's well documented that often stigmatizing, discriminating against specific subsets of our community can lead to creating barriers to health-seeking behavior, meaning people are not engaged in care, people don't go to get vaccinated, or they don't seek a diagnosis and so on. So it's really important, as we're talking about monkeypox, is that we are sensitive to this issue, and that we don't stigmatize the population that is bearing the brunt of monkeypox infections. And we talk about this in terms that avoid stigma and avoid discrimination. Next slide, please. So I think a few conclusions are that the current monkeypox outbreak has resulted in really an unprecedented number of cases globally, with some unique characteristics that we haven't seen with this infection previously. That in the US and New York City, the good news is the current outbreak is slowing, and this may be due to a variety of different factors that I mentioned before. We have disparities that are very evident in terms of who has access to testing, vaccines, and treatment. And these disparities are not only within our own country, our own communities, but there are huge disparities of access to these resources across countries. In the West African, Central African countries, for example, there is no access or very limited access to testing and no access to vaccines or treatment. And of course, lastly, that it's critically important to combat stigma and discrimination in order to advance the health and well-being of our communities and to achieve optimal outcomes for all of our population. Thank you very much, and I'll stop here.
Thank you so much. And now we're going to turn it over to Dr. Chiarilli to talk a little bit more about destigmatizing monkeypox.
Thanks, Alicia. I want to start the few words I have to say about destigmatizing monkeypox by saying that in my experience, the Columbia community and especially the students are really wonderfully sensitive people and super thoughtful, and they really sort of consciously work to avoid stigmatizing people. But we're all susceptible to fear, and thus, we all are capable of perpetuating stigma even when it's unintended. And as Professor El-Sadr has said, there are some really harmful consequences of stigma. And just to review a few of these that she had mentioned before, there's the possibility of neglect, right? There's a concern that the response from government or health authorities won't be sort of robust enough when the health issue or the community affected is stigmatized. There's fear of sort of overt discrimination, concern about bias or even violence against people with monkeypox or people at risk of contracting it. And then finally, there's stigma can really discourage people from seeking testing or treatment, and thereby jeopardizing their health and keeping the virus in circulation rather than sort of promoting health and curtailing the virus spread. What I'd like to kind of spend a few minutes talking about today is the connection in this particular instance between stigma around monkeypox and the focus on sex, right? I think that sex is sort of a bottomless wellspring of so much sort of discomfort and stigma, and the fact that there are connections between monkeypox and sex are definitely sort of contributing to both real stigma and the potential for increased stigma. And we can think a little bit, just sort of a hypothetical example about when sex is associated with an infection, the way that stigma can rear its head, right? We usually don't feel ashamed or guilty or experience intense bouts of sort of self-loathing if we catch a cold or come down with a flu, right? In fact, people sympathize with us, and sometimes we get treated sort of extra nicely. But it's really a different story for other kinds of infections, for herpes, for HPV, right? And the difference is that these other kinds of infections are sexually transmitted. It could even be argued that, flu is much more likely to put someone out of commission than, a chlamydia infection, especially in the rich world where chlamydia can be treated easily with antibiotics and not lead to some serious health consequence. But the flu isn't understood as the result or consequence of something that had so much sort of shame associated with it or stigma around it, like sex. We don't say to somebody, or to ourselves, I can't believe you held on to that subway pole and then wiped your nose after it, right? And you got the flu, right? It's not the way we think about infections that don't have to do with sex. And so I think it's important to sort of keep in mind a little bit when we're thinking about infections and the way that they sort of collect ideas of blame and guilt and shame when they have to do with sex. I think that a concern that I've found voiced in a very sensitive way from lots of people is around sort of messaging around monkeypox, messaging around vaccine eligibility, transmission risk, and testing recommendations, especially because it's been targeting men who have sex with men, right? And I think it's very important, as I think we know, that monkeypox is not a gay disease, in the same way that HIV is not a gay infection, right? Or queer. There's nothing about being queer or gay that makes one more susceptible. You know, this orthopox virus could really care less anything about your identity. You know, I think that's very sort of important to realize. Yet, you know, as we're sort of working to destigmatize monkeypox and stem its transmission and its impact, we really ought to be mindful that the stigma reduction we do needs to coexist with honesty and, you know, with best medical practices. As Professor El-Sadr had mentioned in her slides, the estimates are that, you know, in this 2022 outbreak, that maybe about 98% of infections have been among men who have sex with men. And likely other populations whose partners include men who have sex with men too. And that's a reality that I think it would be sort of silly to ignore, right? Of course, messaging that sort of targets specific communities could definitely use language that's stigmatizing and destigmatizing, but I think it really can be a mistake if we're thinking that targeted messaging itself is itself stigmatizing, if it's conflated with stigmatizing. And you know, and then as a result, there's sort of no identification of particular communities who might be at more risk or might be disproportionately affected, and no sort of recognition of sort of a hierarchy in terms of likelihood of transmission among different people, right? In some ways, it's another consequence of stigma. It could be sort of argued that efforts to sort of avoid stigmatizing language result in omissions of information that really can be useful to people at risk and reassuring to people who aren't at risk. And I think of this because we do a lot of HIV work in the program that I'm thinking of. I think it can feel complicated, but it's important to sort of say that not all modes of transmission of HIV, all possible modes of transmission, are equal. So if we don't have a very clear hierarchy that, say, being the receptive partner in penile or anal-vaginal, penile anal or penile vaginal sex without condoms is significantly more likely to lead to transmission of HIV than oral sex, then we don't really know how to sort of behave properly in order to sort of avoid. And we don't know what kind of messages to give people. So, you know, there still is a lot of uncertainty about certain aspects of transmission of monkeypox, to be sure. But I think that it is important to recognize that there's a hierarchy of risk, right? That contact with monkeypox, physical contact in the form of rashes or sores, is far more likely to transmit the virus than being in proximity to people with the virus, right? And I think that this is important, once again, so that people can make reasonable and effective efforts to prevent contracting or transmitting the virus. And it also reassures people that their day-to-day activities are not likely to lead to monkeypox infections. You know, and another sort of truth is that while certain behaviors are definitely necessary for the transmission of a virus that has a sexual component, there is an aspect of the prevalence of that virus in your community that's very, very, very important, right? So it's the case that in a community or a sexual network where there's very little virus, the chances of contracting the virus are just automatically lower than in a community or sexual network where there's more virus. So I think that it's important to be reasonable and honest about some of these truths about transmission, and not to assume that saying this is stigmatizing or homophobic or anti-queer. In fact, I think it can be the opposite. Luckily, we are able to reassure people, and we are seeing a lot of success with vaccines and with testing and with people changing their behavior, which is great. It's the slides that Professor El-Sadr has shown. And this is such a quick moving situation that it's changing all the time. Even this morning, the New York City Department of Health changed their recommendations for vaccine eligible people. I looked and I was like, oh boy, we're all going to be out of date by the time our possibility ends. So we're moving from in some way also a state of relatively scarce resources. I'm thinking about vaccines and pain management medication and treatments to one where they're becoming more accessible. And hopefully we're moving from the scope of a focus on prevention and treatment that can expand away from the most vulnerable people to all vulnerable people. So I think we're definitely moving in the right direction. Thank you for letting me share my thoughts here.
Thank you. Now I'm going to turn it over to Rick and Catherine to talk a little bit about the medical services and contact tracing process happening at Columbia Health.
Thank you. So what I want to do is talk to you about what would happen if you have any questions, concerns, or exposure to monkeypox. So as you know, medical services is one of the divisions of Columbia Health. And as a reminder, we are your medical home while you're on campus. We're here to help you and care for you. The medical services is organized into 4 clinical teams, and each student has been assigned or has chosen on their own a primary care provider. And that primary care provider is a member of one of those 4 teams. So as a student, if you think you might have monkeypox, you think you might have been exposed, or you just simply have questions, we're available to you. And there's 2 ways that you can reach out to us. The first is to send a secure message to your primary care provider through the portal. Often your physician or nurse practitioner can actually answer your questions in that message. If you need to speak to somebody more urgently, call medical services at 212-854-7426, and you will be added to what's called our TSL, or telephone symptom line. And then a nurse or a clinician will return your call, usually within 30 to 60 minutes. If you do call that, please, the return calls are often blocked or de-identified. So please answer the phone and keep your phone on. Sometimes students call and they forget to leave their phones on. During the phone call, when the nurse or the clinician calls you back, they're going to talk with you to determine your risk and your need for help at that point. If necessary, the nurse will then schedule you for an appointment that day, often within an hour, so that you can be assessed by a doctor or a nurse practitioner. If you're requesting the vaccine for monkeypox, the nurse will refer you to the New York City Department of Public Health, who offers the vaccine in New York City. Medical Services does not have the vaccine. So once you arrive for your visit, the clinician will ask you questions to help determine, again, your risk, and will likely do an examination. If you have an examination of a sensitive area, your genitals or rectum, there will be a chaperone. That is a policy of medical services. If you have a rash and a history that's characteristic of monkeypox, the clinician will take a sample to test for monkeypox, much as Dr. El-Sadr outlined in that slide. If there are many sites of the rash, many samples may be done. People wanted me to show you, it's just a cotton swab. I don't know if you can see this. And that's just rolled on the lesion. So if there were lesions on your genitals and on your buttocks and maybe on your abdomen or arm, then all of those sites would be sampled. It's important to note that this test is covered by the student health insurance, so there's no cost to the student if you have our health insurance. It's also important for you to understand that the clinician will be wearing gloves, goggles, or a face shield and a mask, and that's just standard protocol. And just so you know that would be the case. If the test is recommended and done, then the clinician seeing you will refer you to our contact tracing and isolation management team, and they will reach out to you later that day. And if you're on campus, they'll help you with new housing for the short term. After that visit, the clinician will follow up with you by secure message and or phone call to make sure you're okay and answer any of your questions. And of course, you're always welcome to reach out to that clinician by a secure message or to call, just so we can make sure you're doing okay and answer any of your questions. And now I'm going to hand it over to Katherine.
Thank you. So as Dr. O'Keefe mentioned, our contact tracing team really steps in when medical services first sees that student to help support you while you're pending that result, and then support students if they do get a positive test result once that comes in a couple of days later. So our contact tracing team is really focused on providing individualized support services to support you through isolation. And that isolation could be just a couple of days until your test result comes back, and hopefully it comes back negative. And then you can go back out, resume your life, and go forward from there. If it comes back positive, though, then you're looking at potentially a couple of weeks in isolation until your lesions fully heal. And so our team will be working really closely with those students to figure out what sorts of supportive services do they need from the university to support them through that time. So for some of our students who live on on-campus housing, whether that is our CCC students in the dorms, our general studies or graduate students living in Morningside residential apartments, or our COMC students living on our uptown campus, we'll work with them to figure out what sort of housing support do they need. Are they going to be able to stay where they currently are? And if so, we can talk through how they can reduce the risk to their other household members, or are they going to be eligible and need an isolation unit through the university? If students live off campus, we'll again give them information around protecting or preventing exposure to their household members. We'll also talk through things like food. Do you have enough of your prescription and over-the-counter medications to last you through that period of time? Are you going to be able to attend classes? Columbia does have policies that allow most students to attend most of their classes while they're in isolation for monkeypox when they take certain risk reduction protocols to help prevent any sort of exposure or transmission to any other students in the classroom. But there are some classes such as performance-based classes, PE classes, students uptown who are on clinical rotations where they're patient-facing. Some of those classes aren't eligible for in-person attendance, at which point we refer those students to our colleagues over at Disability Services for some pretty individualized academic accommodations. And so I'll let my colleague from DS provide some additional information there. We also work with Dr. O'Keefe and the other clinicians over at Medical Services to make sure students get all of the appropriate medical care that they need throughout their isolation process. And we also just connect students with any other things they might need support around. Do they need mental health support, whether that's counseling or otherwise? Do they participate in athletics and they need assistance communicating with their coach? Do they have an on-campus job where they need to navigate remote work or taking sick time for a couple of days or a couple of weeks? So our team will really work with students from all campuses at the university to provide that support. And I will turn it back over to Alicia.
Thank you so much. Before I transition to the next speakers, just a quick reminder that if you do have any questions, you can type those into the question and answer feature below. I'm now going to turn it over to Eduvigis and Colleen to talk a little bit about student support.
Good afternoon, and I'm Eduvigis, the psychologist, one of them at CPS. The Counseling and Psychological Services has long known that how difficult isolation periods can be for people in treatment and or recovering from a multitude of illnesses, including monkeypox. So those who have experienced, those students or people who are exposed to monkeypox and have experienced worries, anxieties beyond what is reasonable for them, will likely have a reaction, a strong reaction perhaps, to having to go into any length of isolation period. So the good news, though, is that there are simple steps that we can take to make the discomfort more bearable. And speaking with someone who can support and guide the student through this temporary postponement of your lives is crucial. And our staff at CPS is committed to doing just so. So how students can call us at 212-854-2878. You will get this information in this slide here, or to schedule a telehealth consultation, because even though we have a variety of services that include individual counseling, supportive groups, and the like, you may not be able to access those that in person, so we can talk with you by phone or by video chat. In addition to that, there are virtual support spaces that are targeting some of the common difficulties that people have, such as time management, management of stress, and the multitude of effects of body-mind connection difficulties when we are sick with any medical condition that requires you to stay by yourself for extended periods of time. Of course, there are other resources available. For the sake of time, I will refer you to our website under Columbia Health CPS section, and you can get more information there. But now also beyond CPS, how you are able to access 24/7 free confidential services through New York City, and New York City Well is one of those resources. It is important to remind yourself, if you have been exposed and you are required to be in isolation, to give yourself permission to ask for help, even if you are not sure that you need it from any of us at CPS. In addition to that, maintaining your routines, good sleep, and attempt to eat regularly. If your body allows it, move around the room if you're not allowed to leave your room. And also reach out to the people in your life who have been a source of support in the past. Research tells us that people who have friends and connections with others do better and recover better from any medical condition. So reach out and remain open to making new connections through the services available on campus and the students' organizations that will support you through this. And in the service of time, I will pass this on to my colleague Colleen for additional info.
Thank you. My name again is Colleen Lewis. I'm from Disability Services. I think all of you may know that we work with students who have permanent disabilities, but in addition to working with students with permanent disabilities, we also work with students who have temporary injuries or who have a temporary illness that's lasting a few weeks. In thinking about supporting students who may need accommodations and disability services who have monkeypox, we've streamlined the registration process. So we'll work closely with our colleagues in medical services and contact tracing to expedite the registration process and to think about accommodations and support services for students on an individual basis. There's so many variables when we think about accommodations, and they're course dependent, the type of class that a student's taking, if a student's able to participate remotely, if the student's able to engage in academic work throughout the entire duration of their illness, or if they need some extended absences and then time to catch up on their work. There are a variety of accommodations that we can put into place to support students during their illness and the recovery from their illness. For students who are not diagnosed with monkeypox from a Columbia Health clinician, students can contact us directly by contacting us at disability@columbia.edu. A member of my intake and registration team will be in touch immediately to to connect with the student to determine how we can best accommodate them and support them through their illness. And I'm going to turn it back over to Alicia at this point.
Thank you all so much. One final quick reminder, the question and answers is open at this point. So if you do have any questions, we do have two that came in during our registration process. So the first one is, does the Columbia Student Health Insurance cover the test?
Yes.
Thank you, Dr. O'Keefe. Simple answers to simple questions. I like it. And then our other question that came in is, will we be getting the vaccine, or do we know if we will be getting the vaccine?
I think that it's not available. I think it's only available through the New York City Department of Health. So it's not really going to come to Columbia Health.
At this, yes, just to add, I agree with Rick. I think at this point in time, there is still remains a limited supply of the vaccine in view of the demand, the high demand and limited supply. So I think at this point in time, because of that, the Department of Health is the only entity that's providing vaccination. But that may change in the future, of course, as more supply of vaccine, the vaccine becomes available. That I'm certain that if that happens, that there'll be an easing of the restriction and making the vaccine more widely available.
Thank you so much. Not seeing any other questions at this time. Oh, no, one just popped up. How can we support our friends?
I'll take that one. I think it's super important that if you know somebody who has been exposed to monkeypox, that you offer support. Don't wait for the person to ask you for help. Just a regular check-in. How are you doing? Is there something you need? Is there anything I can do for you? That enough is incredibly supportive, even if the person replies with, "Thank you, I'm okay." And then call them again, text them, video chat them.
Also, just to add, I mean, one dimension of support, just to add to what Eduvigis said, is to point them to the available resources that are remarkable at Columbia Health. Just listening to all of the speakers is to point them to, if they're worried about that, they should, or they have symptoms, go and seek clinical care, go and seek the resources that are available. So I think that can only be, sometimes there's so much stigma associated with it that people are reluctant to speak about it, reluctant to seek services. So I think the more we can, all of us, point people to where they can get the resources they need, I think that'd be fantastic.
Okay. Another question that has come in, who can I talk to about if I should get a test or if I have other questions?
I think the first person is contact your PCP on campus. And then if you don't have a PCP, you can contact me, or you can call the TSL line at 212-854-7426. And I believe Alice and Jihad would be available to help you as well.
One thing I'd like to add, I agree with Dr. O'Keefe, those are great ways to move forward, is that the testing, just to reiterate what other people have said here, the testing is for people who are noticing some sort of rash or symptom, right? So it's collecting some of the specimen itself. So there's not a blood test, for instance, that's looking for some evidence of infection for people who aren't noticing anything, right? So it's if you notice something on your body that's unusual, that's when it's a great idea to contact your PCP with a telephone symptom line and let them know your concerns.
Thank you both. Another question that has come in is, will my information be kept confidential?
Yeah, I can take this one. So broadly speaking, yes. So our whole role here at Columbia Health is to support you through this. And when contact tracing first speaks with a student who either has a confirmed monkeypox diagnosis or is suspected and pending that test result, we're going to talk through what sorts of resource support do they need. And when we set those up, we're not disclosing that it's a monkeypox diagnosis or suspicion. Contact tracing, like monkeypox, may be new-ish to the New York area, but this is not our first rodeo. We've been supporting students with COVID and other infectious diseases for over 2 years now, and we have a host of relationships with our campus partners. We can just reach out and say, this student needs this support service without indicating why. And we've set up those relationships so we can get those students support. We can get them housing, we can get them other support services, we can facilitate that connection with counseling to let them know this is what the student needs, but not disclose that reason. Similarly, with connecting with faculty, faculty will know that you need to be out of class, but they're not going to know the reason. There's so many reasons why you may need to miss class or you may need to move a dorm room temporarily. We're going to be protecting your confidentiality throughout that process.
And I just want to echo everything that Katherine said. If you receive accommodations or support services through disability services, your faculty is not informed of the reason why, but rather the accommodations and the support that you need. And we'll talk through with students any concerns that they have about confidentiality. But the reason why a student's receiving a particular accommodation can be many, and that is never shared with the faculty member.
Same here. CPS is a fully confidential and private service.
So is the medical services.
All right. Well, at this point, I would ask for the resource slides to pop up on the screen. Thank you so much. Just wanted to quickly go over, if you do have additional information or you would like to eventually share this webinar with people that you know who may not have been able to be here today, you can go to our website about monkeypox. You can also go to the Go Ask Alice website to get information about questions that were answered about monkeypox. And for information about where you can get tested, again, this was shared earlier, but the vaccinefinder.nyc.gov.